Good evening, all. So, we shall be beginning with a CGR from Neuro-Surgery department. It is on high cervical spinal cord injury, whether it's a lost cause, or a glimmer of hope. It's my pleasure to invite Professor Kamran Farooq sir to say a few words.
Thank you very much, Dr. Surya. So, we all know that cervical spine injury is a very dreaded sort of a morbid trauma injury, and especially because these patients who have complete injuries, they have very dismal hopes of coming out alive. First of all, if you then don't get treatment, in olden days, if anybody got a cervical spine injury, we would assume that they're not going to go out of the hospital. At least we have advanced quite a bit from that point of view. That at least quite a few patients have the hope of coming out alive from the hospital and going back to their home. However, especially complete injuries, they are dependent on the ventilator, and most of them go on the ventilator. It is very difficult to maintain them without ventilator. So if they are able to go home either on ventilator or without ventilator, I think it's a great cause of hope, and it's a matter of pride for the patient as well as the doctors who are able to treat these patients. So, neurosurgery has been treating spine injuries for a long time at trauma center, and let's have a look at our data and what have we achieved and what is more to be achieved. Thank you.
Thank you, sir. So, as we are all aware, one-third of spinal cord injury patients have complete spinal cord injury, and about 80% of those with traumatic cervical spinal cord injury remain paralyzed, and about 40% of them remain ventilator dependent. There are a huge economic burden, not only to the patient but also to the caregivers and the society. It is associated with multiple short-term and long-term morbidity and also mortality due to various factors like pneumonia, recurrent UTIs, septicemia, pressure sores, and thromboembolism. This is the data derived from National Spinal Cord Injuries Statistical Center based in US, which releases the annual demographic data. It has been releasing for the past 50 years. So the data for year 2023 shows that there have been around 18,000 new cases added to the total spinal cord injury cases, with vehicular RTA being the most common cause of the injury. And about 12% of patients having high cervical spine injury, that is complete tetraplegia. But there are also patients who have incomplete tetraplegia. They have not classified based on Asia level, but based on these parameters. They have found that those patients who are ventilator dependent, their life expectancy is extremely reduced compared to any other kind of injury. And they are a huge economic burden to the society. This is the economic cost borne by the society in the first year of the treatment, and this for the each subsequent year. And considering the life expectancy, this is the economic burden borne by the society. So there are also many moral and ethical issues. Patients who sustain cervical spine injury, whether the patient is willing to take care of the patient or not, or does he want the patient to die, and what is the social liability and the economic burden, it is not described. So coming to pathophysiology of spinal cord injury, the primary injury is due to direct impact, that is at the time of trauma. And the secondary injury is either due to edema or contusion, extension of the contusion. And there are various post-operative factors which affect the prognosis of this patient due to they are predisposed to neurogenic shock, and they are ventilator dependent. They are susceptible to ventilator-associated pneumonia, pressure sores, venous thromboembolism, and ultimately sepsis, which is the biggest killer in these patients. So there are various strategies that have been described historically to tackle cervical spine injury. The main role is to decompress and to stabilize. And there have been research reports by Phalanx et al., which proposes that early intervention, that is within 24 hours of injury, has these patients tend to have good outcome. And also studies where they have targeted a higher mean arterial blood pressure for a period of 5 to 7 days post injury. But there are a lot of treatment gaps in treatment of spinal cord injury. There are various medical measures which have come up like riluzole, but the treatment effect is doubtful. There are newer treatment therapies which have started based on the concept of spinal cord perfusion pressure, similar to intracranial pressure. So that is one treatment modality which is being tried. And whether surgery alone is enough, or is there a role of new treatment modality like duroplasty, which concentrates on something about the spinal cord perfusion pressure. So these were the questions which arose in our mind. So what are the demographics of a deadly disease like complete cervical spinal cord injury at our institute AIIMS, and what are the outcomes? So now I call upon Dr. Akshay to discuss the study findings.
Good evening, everyone. I'll be continuing with the study. So basically, in our study, we evaluated patients from August 2018 to December 2023. We excluded the year 2020 and 21 because of the COVID-19. So we didn't have patients in that. A total of 146 patients were evaluated. And our criteria was that we specifically chose patients with cervical spine injury and those specifically with AIIMS status. And these patients were evaluated for a follow-up of minimum of 6 months. In this, we have counted for the AIIMS, which is basically the patients will have no motor or sensory response and the anal tone will be absent. So in totality, from the level of lesion below, there will be complete loss of innervation. Having a look at the age, we noticed that the age group that was affected with the trauma was highly variable from 4 years of age up till 71 years. But most commonly, the age which was more commonly affected was the adult age, and that is 36 years were most commonly seen patients. Coming to the gender predisposition, around 84% of the patients who were predisposed to this trauma were males, and females were accountable to 16%. The mode of injury that was most commonly involved in these patients was history of fall, that is 72%, and it was followed by history of road traffic accidents in 23%, and bone injury and unknown mechanisms were accounted for 3 and 2.5% respectively. The patients who had associated head injury with cervical injury, which was concomitant, was around 15%, and 85% did not have any associated head injury. We found that the level of injury was most commonly seen at C5, which was around 61 of the patients among the 146 patients, and this was followed by C4 and C6 levels. Majority of the patients that came with the injury, around 75% of them required intubation preoperatively, and around 25% maintained themselves at home. Next, I will be inviting Professor to guide us in radiology.
So I'll be speaking on the role of radiology. Radiology plays a role in basically characterizing the type of injuries and often also helping in surgical planning or even prognostication of these patients. So first modality which is described, if there is an indication for doing imaging for a cervical spine, for a clinically suspected cervical spine injury, the protocols say that cervical spine CT is the modality of choice. There is no more a role of doing a radiographs in this particular case. Erstwhile it was done. Any center which does not have a CT scan, then maybe you can take help of doing the radiographs. But if the CT is available, or if you have the facility to manage these patients and you have a CT scan, then CT scan is the modality of choice. We try and characterize them. There are multiple classifications based on the morphological patterns which are given. Two most common classifications which are used are the AO spine classification and the SLICS scoring system. Both of them in the imaging have described morphology of the fracture or the injury, which is seen predominantly on the CT scan, and then status of the various soft tissues, which are the ligaments, which are better characterized on MRI scans. So looking at the morphology of the scans on CT scan, where I'm showing you multiple examples. This is like a wedge compression or a compression injury in which only one superior end plate is involved. Then it can be a burst fracture where there is an end plate injury along with a posterior vertebral margin injury. Often there is a retropulse bony fragment which is seen in the spinal canal. A special type of injury could be a flexion teardrop injury in which there is an anterior-inferior part which is a triangular or a quadrangular space, small part of a fracture in which the rest of the vertebral body shows retropulsion in the canal, and it is often associated with a significant spinal cord injury. Then there can be just flexion distraction in which there is opening up of the posterior tension band. As you can see on this CT scan, the posterior intervertebral space is slightly widened, the anterior one is slightly narrowed, and there is an increased interspinous gap between the spinous processes there. This is classified as a flexion distraction type of injury. Another example again showing a slightly more flexion distraction in which there is even a purged facet which is seen on this particular image. On the other hand, there could be extension distraction type of injury also in which there is an anterior widening and posterior tethering which is seen. So the anterior disc space is widened. This particular type of injury pattern is most commonly seen when there is a stiff spine or in cases of degenerative diseases. This was an example of a AIIMS patient, and these type of injuries are common with these patients. Then there could be a translational injury in which there is a listhesis of superior vertebra over the inferior vertebra by more than 3.5 mm in cervical spine. We classify it as translation. In this case, it is almost a grade 2 anterior listhesis. And as we go in the parasagittal sections, we can see one of the facets is jumped and the other facet is actually perched on the top of the other facet. And we can characterize them better with a good quality 3D reconstructions scans like available. And on the axial scan, you can see that the articular surfaces of the two articular processes are actually not opposing each other, but they are causing what is seen as a reverse hamburger sign. Besides these pattern of injuries, there can be isolated injuries of the vertebral bodies. More often, isolated injuries of the spinous process, like seen on the sagittal and the axial section, or isolated injuries of one of the articular process or the facets, which are then characterized separately. There is a role for MRI because CT will not tell about the soft tissue. It will just predict the involvement of the soft tissue. It is best characterized on MRI. So for any case in which we are suspecting either a cord injury or ligamentous injury, and it helps in changing the management, we go ahead and do a MRI on these patients. So this was the same patient which I had shown you as a burst fracture in which there is a retropulsion of the bony fragment in the canal. As you could see in this particular case, there is obliteration of the anterior thecal space and small indentation over the cord surface with minimal signal changes, T2 signal changes in the cord. This is probably just small mild cord edema secondary to a compression by this particular bony fragment. In contrast, in another patient in which there was a distraction injury, so CT did show that the canal seemed fine, but when you do a MR, and of course it is clinically evident if the patient is having either ASIA or a B status, you can see that there are signal changes in the cord which are ranging from C3 to C6 in this particular case. It is longitudinally long segment, and there is a small hypointensity on T2 weighted image also, which characterizes it as a hemorrhage. So there is a hemorrhagic contusion in this particular case. Besides that, you can also comment upon the status of the ALL or the PLL, as you can see in this particular case. Another example, another case of translational injury in which there is a significant canal compromise and a large area of contusion, hemorrhagic contusion. This is hemorrhage seen on dark on T2 weighted image, hemorrhagic contusion involving the cord. Besides that, in this particular case, there is a disc injury also. So that helps in planning the surgical management. There is a clear injury to the disc, and there is anterior longitudinal ligament disruption as well as PLL disruption, as well as interspinous ligament injury also, which is seen evident on this axial sections also. Another example, in this case, again, the CT was almost normal in terms of the canal, there was only a spinous process fracture which was seen. However, there was a ASIA-B status of the patient, and on MR you could see that there was a traumatic disc extrusion which was seen, not just extrusion, it was a cranial migration also, and MR was able to characterize the disc injury also pretty well, which was then compressing upon the cord, leading on to a cord edema in this particular case. Sometimes the MRI is not just looking at the soft tissue injury, but it also helps to characterize if there is any associated vascular injury also. We can either do a CT angiography if we are suspecting vertebral artery involvement, especially in the cases where the fracture is running through the foramen transverse area. However, if the MR is being done for evaluation of the cord, it is equally well modality to characterize the vascular injuries. In this particular case, there was extensive cord contusion and edema, and as you can see, the edema is spreading right from the corticomedullary junction till the upper dorsal level. But on the axial sections, you could see a loss of flow void of the left vertebral artery. There was also infarct in the left cerebellum, and the MR angio which was done showed non-opacification or non-visualization of the left vertebral artery. In some cases, we do not see anything again on CT scan, but when you do a MRI, you just see only involvement of the cord. There is no ligamentous injury, no disc injury, no posterior PLC injury, but just involvement of the cord. These patients are classified as Skywora, which is spinal cord injury without any radiographic or radiological abnormality. It means that the MRI can show the abnormality, but not the X-ray or the CT scan. And this is more commonly seen in children. However, we have seen patients, adult patients also showing this. Thank you.
Thank you, sir. Now I call upon Dr. Varun to discuss the anesthetic concern.
Good evening, respected faculties. I'll be continuing the topic with regards to the concerns faced by us as anesthesiologists. The immediate life threats faced by a patient who has a spinal cord injury. Firstly, we start with the basics, the airway, breathing, and the circulation. In the airway, we have to perform an early intubation if the patient is developing signs of obstruction, and we have to maintain a close clinical monitoring of the airway patency. For the breathing, continuous monitoring of the peripheral oxygen saturation, frequent blood gas monitoring, and use of end-tidal capnography or serial measurements of the pulmonary function. In circulation, systemic hypotension is common due to neurogenic shock. So rapidly differentiation from other causes of shock, ensure the euvolemia, and initiate vasopressors early. Continuous blood pressure monitoring should be done, and replacement of arterial catheter should be done. Once we know the patient needs to be intubated, we assess the airway and the oxygenation. It can either the patient might be having an apnea or in respiratory distress, or could have adequate oxygenation. If the patient is having respiratory distress, this is the emergency airway. So intubation in the most efficient manner should be done, maintaining manual inline immobilization, avoiding neck extension or jaw thrust. Once the airway is secured, we can do a radiographic evaluation. If not, we go to our difficult airway guidelines, which is mask ventilation of LMA, and we avoid jaw thrust and chin lift. If still there's inadequate ventilation, jet ventilation, surgical percutaneous airways, retrograde intubation, or other options should be considered. Whereas adequate oxygenation and elective airway is considered, and the process is followed in the similar manner. How do we stabilize the spine during intubation? It can be done using the hard collar as seen out here. The sandbags are placed on the either side, a backboard is present, and the head tapes are placed. The other method could be a soft cervical collar, or by manual inline stabilization or immobilization, which can be done from the head end or from the foot end of the patient. How do we intubate the patient? It can be done using direct laryngoscopy, but this causes extension at the occipito-atlantal and C1, C2 junction and flexion at the neck. The second option is video laryngoscope. Overall, the spine movement is reduced by 50% as compared to direct laryngoscopy, and it does require a Mills maneuver. The most commonly used method by us is the awake intubation. It is considered safe in patients with spinal injury. Oral or nasal intubation can be done. The normal muscle tone provides protection. Neurological status of the patient can be monitored. It is slower compared to the rapid sequence intubation and requires cooperation from the patient along with the expertise of the operator. The last option which remains with us is the surgical front of neck access. In the emergency, a cricothyroidotomy can be done. And this may also be associated with movement of the cervical spine due to extension of the neck. In the ICU, we face a lot of complications which we need to look after. The major ones in the cardiovascular system, usually we see autonomic hyperreflexia, decreased blood volume, orthostatic hypotension. Respiratory system shows muscle weakness, decreased respiratory drive, decreased cough. Proliferation of acetylcholine receptors and spasticity is seen. Recurrent urinary tract infections and altered bladder emptying. Gastroparesis is there. Urinary tract infections can be there, pneumonia and decubitus ulcers along with sepsis. Anemia, risk of DVT or pulmonary embolism. Bone density decreases, causing risk of osteoporosis, and postoperative pain or chronic pain can be seen in such patients. Now, what is neurogenic shock? Hypotension occurs when the lesions are above the level of T6. This is due to the loss of the sympathetic autonomic function and unopposed parasympathetic function. Vasoconstrictor tone is lost and venous pooling occurs. Due to the loss of the cardiac accelerator fibers, this results in bradycardia and patients are unable to increase the cardiac output by changes in the heart rate. The duration of the neurogenic shock is variable. Recovery tends to be incomplete and postural hypertension may be a persistent problem. As we can see, there's reduced preload, reduced stroke volume, reduced afterload, and reduced heart rate. All of this reduces the cardiac output, causing neurogenic shock. Now, according to the level of spinal cord injury, the respiratory function can be seen. Above the level of C3, we have zero ventilatory function, zero cough. This is due to the paralysis of the diaphragm and the accessory muscles, and it results in apnea. C3 to C5 can have some ventilatory function due to partial paralysis of the diaphragm. C5 to 7 has ventilatory function and cough, and this is due to paralysis of the accessory muscles, whereas the high thoracic has partial paralysis of the accessory muscles. How do we reduce the pulmonary complications that we see in the ICU? Aggressive pulmonary hygiene by frequent suctioning, positional changes every 2 hours, assisted cuffing devices, exercises, incentive spirometry, bronchodilator therapy. Bronchoscopy can be used in case of atelectasis, early institution of mechanical ventilation in labored breathing, and close monitoring with optimal use of PEEP and limiting our peak pressure to less than 30. This is our perioperative concerns. Once the patient has been stabilized in the ICU, he is ready to be taken up for surgery. The preoperatively, we see the history of the patient, the physical examination, and the neuroprotection. Our airways managed as described earlier by awake fiber optic, direct laryngoscopy with Mills. Induction, we have to avoid hypotension and using depolarizing muscle relaxants like scoline. The BP should be maintained with a MAP between 85 to 90 and a bradycardia treated. Normocarbia, normoglycemia should be maintained. In the postoperatively, respiratory insufficiency is expected. Therefore, we have to be careful while extubating, and thrombus and prevention of infection. How do we wean the patient from mechanical ventilation in the ICU? The first step has to be early and aggressive management of the secretion clearance. Selection and frequency of suctioning should be determined based on the amount of sputum and the efficacy of secretion clearance. Moderate PEEP can be used to maximize the recruitment of collapsed lung area, and this can further improve the pulmonary function without compromising hemodynamics. In the third step, it is timely transition to spontaneous breathing mode to preserve the diaphragmatic function, and close monitoring of the vitals, respiratory rate, tidal volume, respiratory distress, hypoxemia, tachyarrhythmia. Last step, early tracheostomy and humane care should be provided. Patients with a spinal cord injury of C4 and below are potentially weanable. Thank you.
So we'll see what we have, how we have managed the 146 patient from the August of 18. So there are two kinds of approaches, anterior or posterior, or both of them can be combined. But specifically in this patient population, we have seen that anterior approach was mostly used in 51% of the patient, while posterior approach was done in 21% of the patient, and 360 degree approach was limited to 14% of the patient, which is more or less at the level of C7 D1 injuries, which requires junctional stability. And conservative patients are the patients who were not fit for the surgery, or either they do not need surgical decompression, but they are clinically ACI. So postoperatively, 76% of the patient underwent tracheostomy because of poor secretion clearance or poor respiratory drive, while 35 patients or 24% of the patient who had lower cervical spine injury were able to be extubated. 43, that is almost 1/3 of the patient died during the hospital stay, and we were able to discharge around 71% of the patients. At the follow-up, around 54% of the patients were lost, and 13% of the patients remained the same, and 15% of the patient improved to some extent, either to Asia B or Asia C, and 20% of the patient require, as we know, these people require chronic nursing, prolonged nursing care at home, so not the mortality rate remains high even after at the time of follow-up. So this is a paper from our institute which analyzed the mortality profile of the patient with traumatic spinal injury. And here we can see that in the phase 3, that is within the first week and after the first week, the sepsis remained the predominant cause of the death, as well as the male gender and the middle age to young group, and cervical spine injury was very one of the most common injuries in this paper. So I'll call upon Ms. Nidhi from physiotherapy.
Good evening. Hello. Good evening. As a physiotherapist, we play a crucial role in providing hope and support to the individual with cervical cord injuries, and physiotherapist expertise and can create a profound difference in helping patients maximize their potential and regain independence to the best of their abilities. As we know that there is compromised chest respiratory function of the patient in case of high cervical injuries, so there is retention of secretion. So in order to mobilize those secretion and to help in preventing the ectasis, chest physiotherapy, different techniques are performed, like percussion, vibration, and manual hyperinflation is done in order to help in increasing the expiratory flow rate of the secretions and helping in cuffing them out. This is the cuff assisted device, which again helps in creating a positive expiratory pressure and thus helping in making the mobilization of the secretions. Incentive spirometer is given to the patient to help in giving him visual feedback and helping in increasing the vital capacity. The abdominal binders are given to the patient to help increasing the abdominal pressure and elevating the diaphragm and helping in increasing the vital capacity of the patient. Postural drainage is given to the patient to help in mobilizing the secretion. And this is the vibration technique which we perform. Now, in case of physiotherapy management, as this condition requires long-term physiotherapy, so passive exercises by the motomed instrument and providing braces, splints in case of pocket splint, as we see there are contracture development in case of hand, and tightening of the lower extremity. So AFO is given. And DVT is found in the patients to stockings, compression. Stockings are given to the patient. In case of orthostatic hypotension, gradual lifting of the patient from supine to standing is performed. To prevent pressure sores, regular turning after intervals of 2 hours is given to the patient. For pain management, TENS therapy is provided. So this is the summary of the physical skill training which is given: ROM exercises, long leg sitting, parallel bar standing, upper limb strengthening, tilt table standing, walking with orthotics, mat exercises, transfer training, and outdoor ambulation. This is mostly in case of if the injury is below C3 or below C3 level. Because in case of C1, C2 injury, there is weaning from ventilator is a very big problem. So this can only be done in cases of patient where the level of injury is below C2. So here mobilization in bed can be provided, but here these are all very expensive modalities, and so for in normal circumstances it is not affordable. Upper limb strengthening exercises are to performed so that the patient can do all the activities. Still, the power is there if in case of upper limb, so he can use that power and perform his activities of daily living. Balancing technique so that he can sit on the wheelchair and maintain balance. In cases of this is wheelchair transfer techniques which are taught to the patient, so he can mobilize himself. And because as upper extremity there is no power in upper hand or partial power is there, so electronic battery operated wheelchair is also provided. The patient can get it and can make his mobility improve. And these are all the assisted devices which are now available for the patient to be more tech savvy, or he can lead his normal life as much as possible, and he can make his life more socially acceptable, and can lead like a normal individual.
Thank you, Ms. Nidhi. So I'll be discussing one of the success stories that we see. So this was a case of 30-year-old male. He had presented more than 3 days since injury. He had a C5 flexion teardrop fracture with a C6 split fracture, and MRI showed associated cord edema and cord contusion. He underwent C5 corpectomy with anterior plate fixation. At the time of discharge, he was still Asia A, but at follow-up that is of more than 1 year, he is currently, and he had a prolonged hospital stay of 1 month with ICU stay of 14 days. So this is the current status of the patient. He is describing his the mode of injury, and as you can see here, he is able to walk, which is a very good success. So, comparing our study, which our study has about 10% of improvement in the follow-up, and about 40 to 40% patient have expired. This is one of the major studies which are published, which is a study comparing early versus delayed surgery. That is surgery within 24 hours and surgery after 24 hours. As you can see, patients who had a preoperative grade of A, overall, they have seen that majority of the patients, that is 42 out of 71, remain same, whereas very few patients show improvement. So the way to go ahead is to get these patients early and to intervene in them early, and to have a good post-operative rehabilitation and follow-up, and to start preventive measures. That is at the before preventive measures to decrease the rate of fall from height and root of cancer, and to have a robust rate. Now I call upon Professor Deepak Agarwal sir to tell the concluding remarks.
So I think one of the biggest advantages of this CGR is that we could get our data out on high cervical spinal cord injuries and have a follow-up. So I think Surya and the residents we have, they spent a lot of time in getting follow-up and seeing. And we were also surprised to see that 15% of the patients had improvement, which is amazing in a completely cervical cord injury, which we never expect. And some of them obviously have a long follow-up, more than a year, as we can see. So to finalize, to conclude this presentation, we would say that aggressive management is warranted, and we should not have a very negative attitude towards them. And from my perspective, this is what I could find. This is one of the world's largest studies over 3 years or so. So 150 patients over 3 years, high cervical or cervical complete spinal cord injuries. I don't think anybody has. So we have, I've asked Surya to have it published, write it up nicely. And I think this itself is a very good thing. So thank you, all of you, for coming. Obviously, we are open for questions.
In your study, you will find a difference between a early decompression.
So that was not the aim of the study, because most of
In your experience generally,
yes, yes,
not maybe statistics, but
yes, the early intervention has a good outcome. The problem is we generally get patients at a delayed presentation.
by
Our
early you mean within 24 hours the surgery.
surgery needs to be done. That is from the time of injury to the time of incision. Although we take all efforts to operate them the next day itself, but they are already presented late.
Does it help only for the preventing the secondary complications?
Yes, sir, because the primary injury is already happened. Our aim in cranial injury and cervical spine injury is to
If the neck has been stabilized to start with, right now, itself does make a difference.
yes, sir, because of the primary impact, the secondary injury sets in. If we do not stabilize, it rapidly progresses.
Non-surgically, if the neck immobilization is done properly.
Yes, sir.
Then
That will not hint, that will not stop secondary injury. Decompression. So this the role of early surgery is for any kind of cervical spine, any level that is complete to incomplete. So it is more beneficial if it is an incomplete, but it also has a role in complete spinal cord injury, as I've shown that there is improvement in the follow. Yes, sir. So the complete injury is a heterogeneous group. The point is well taken, sir. In the case of transection, there's no prognosis. But in other cases, where there is cord edema, cord confusion, yes, there is even in complete spinal cord. Yes. Yes, sir. Yes. Functioning. Yes. So out of the 15, yes. Yes. Among the 15 patients, 5 patients could work with support. The rest of them had grade 1 or grade 2 improvement. Yes. So most of the patients are, Dr. Rajas said, they have expired due to pressure source.
See, I just want to make one more point. Improvement in the grade is okay, but improvement in respiratory function is not captured by any of these scores. So if the patient is able to be weaned off ventilator, that is also improvement in something. So I think that is a huge benefit in start these patients off. That itself we should like a separate paper. Start who are on ventilator from day one.
Yes. So that is an ideal situation. And it was a multi-center process. Yes. Sir. Yes. Thank you.